Okay, let's talk about one of the two most common tendon repair surgeries. So, rotator cuff repair, Achilles tendon repair. You're going to see a lot of both of these throughout your career. Probably rotator cuff a little bit more frequently than Achilles tendon, but Achilles tendon repair is another biggie. And this is one that when I first came to China in 2015, I was seeing so many complications related to repair, re-tears, really, really bad rehabilitation situations with patients. So I'm hoping, I think it's better. I think in the last 7 years, we've definitely seen improvements. So we're going to talk about really what the important things are related to Achilles tendon repair. Let's start with a fun video.
因为刚才这个1把卡这个是让大伙儿都坐下，别喊，就是刚要欢呼。1把卡。
Yeah, that makes me sad. That's a very good example of a basketball player doing their normal stuff.
因为刚才这个1把卡这个是让大伙儿都坐下，别喊，就是刚要欢呼。1把卡。
Pushed off and there it goes. So, Achilles tendon. I think we all know anatomy. I think we know where the Achilles tendon is. So I'm not going to go into too much detail here. It attaches to the calcaneus. I think we all know it comes around the calcaneus, attaches to the soft tissue under the bottom of the foot. You can see here, this is kind of a cross-section, again, of the anatomy. So if you look at the very bottom of the picture, you'll see where that Achilles tendon is in relationship to all of the other soft tissue around the lower leg. So it's a pretty big, thickened tendon coming from our calf muscles. So basically our plantar flexors, especially the gastrocnemius, but also the soleus, will kind of come together into this one shared tendon that comes down to attach onto the ankle. And so just kind of a reminder of what are our plantar flexor muscles, primarily gastrocnemius and soleus, but also our flexor digitorum, our flexor hallucis longus, our plantaris, and our tibialis posterior are also going to help with plantar flexion. So when we have an Achilles tendon tear, we're not losing every bit of plantar flexion, we're just losing a huge, basically the major muscles that are doing that plantar flexion. So how does this happen? It always has to do with blood supply, doesn't it? So blood supply in the central part of the tendon, so where about 2 to 6 centimeters proximal to the calcaneal insertion, so 2 to 6 centimeters up from the very bottom of the heel, or the very back of the heel, I guess you would say, is there's not very good blood supply. And so you can see on the left side, when the tendon is unloaded, and this is really true with any of our tendons, it's not that beautiful straight line, and then when it's loaded, it becomes that beautiful straight line. So those collagen fibers are all straightened out, and then as we, if we load it too much, then that's where we get our tears. And there is a little bit of, how do I want to say this? There is the ability to store energy within the tendons, which we talked about when we just talked about tendon pathology and, tendon anatomy in general. And so you can see that you've got that ability to give some stretch, but then there's that stress, strain, load issues that we have to talk about, that if we're stretching it too far with too much power, then that's when we're going to get the tear. So that's essentially what this says. Mechanical loads exceed our capacity. There could also be situations where there's repetitive microtrauma, which we've seen with a lot of the other tendons. So if we're already getting small little tears that maybe cause a tendinosis. So, we have Achilles pain. There's an entire clinical practice guideline related to Achilles pain. if somebody has been, loading it incorrectly, and there's already irritability, and then they go play tennis, or in this case, this is a girl playing badminton, and they load it kind of regular, what we would say, not overloading it, but there's already some tears, then you could lead to a full Achilles tear. The other situations where we're going to see this, if they push off with full knee extension or extending the knee, so with things like sprinting, that's a big one, then we're more likely to mechanically overload the tendon. When we're in full weight bearing, if we have to do like sudden dorsiflexion, which could happen with like a fall, so like the foot could get into the wrong position and you could have a fall, or if you're having to totally stop yourself during a run, you're gonna put your foot down, plant your foot, and go into a huge amount of dorsiflexion. Those things could also cause a tear. And then if you're jumping from a height, so if you're up on a big, like jumping off a building, basically, you land on a foot that's plantar flexed. So again, you're trying to land and your foot is in full plantar flexion, then you get pushed into dorsiflexion, then you could also tear from that contraction. I'll be honest with you, most of the time, when we see this problem is with patients that we're calling weekend warriors. So it's these patients, and I'll move on to the next slide, oftentimes men who maybe don't exercise a huge amount, so they might be a little bit overweight. They are not doing like normal exercise where they're loading the tendon regularly, but maybe on the weekend, maybe not every weekend, but on weekends they decide to go out and play tennis for the first time in a long time, or it happens a lot in baseball. So guys, are standing around most of the time, but then they have to sprint from one base to another in baseball. And so their tendon is just not used to being loaded, and then they load it really hard, really fast, in kind of a stressful sports situation. And so those are the ones that we tend to see. That's the story we hear. It's usually slightly older people, so males in their 40s, sometimes even 50 years old, who tend to get these tears. So it's not your young people who have a little bit more flexibility in their tendon that tend to have these tears. And again, stop and go sports, very common. Tennis, football, badminton, squash. If their mechanics aren't very good, they don't do a lot of running, but then they're trying to do a bunch of running all at once. And then we talked about steroid use being a problem. So if they're using steroids for any reason, they're just trying to bulk up their muscles or whatever, or if they have some sort of disease where they need to use steroids or anti-inflammatories, then they're more likely to get a tear. 25% of the injuries are in sedentary patients, so it's not very often. When Kobe, this is a picture of Kobe Bryant, when he actually tore his Achilles, he was already 36 years old. So he had been, loading that Achilles for a long time. And so, it was a little bit surprising because we talk about how load is great, but maybe that, he hadn't been loading it quite perfectly for a while or something like that. And so he ended up causing that tear. So most of the time, this is a pretty obvious injury to diagnose, okay? Most of the time, they're going to say that they felt a pop, like someone shot them or they got hit by something like a little rock or something against the back of their ankle. So it's going to be pretty obvious. You will oftentimes be able to palpate the deficit, and I'll show you guys a picture of that. You'll be able to feel the area between 2 and 6 centimeters above the calcaneus, above, like I said, kind of the bottom of the back of the heel. Just go up 2 to 6 centimeters, and you'll usually be able to feel it. Positive Thompson test, which we're going to show, I'll show you a picture of that in just a second. And then the other option is an MRI. But what they found, so you have to keep in mind, in Western countries, we don't do MRIs very often. Western countries, MRIs are very expensive. And so doctors will oftentimes try to do everything else that they possibly can before they do an MRI. And what they have found is that these 3 tests put together actually are more accurate at diagnosing an Achilles tendon tear than an MRI. So the first test is called the Madel's test. And a Madel's test is basically just looking at them. So you're going to put them in prone. So all of these are in prone, which is nice. Prone, bend the knees, and then look at the resting position of the foot. So you can see here that in this case, the right foot is in more dorsiflexion. So the foot that's closest to the camera is in more dorsiflexion than the left foot. So the left foot has an intact Achilles tendon that is shortened in this non-weight bearing position. And so you'll notice that they're in a little bit more plantar flexion, which is normal. The right foot, because there was an Achilles tendon tear, is actually in a resting position in more dorsiflexion. Okay, so that gives us the possibility that there's a tear, because again, they don't look the same, right? The right foot looks like it's in more dorsiflexion because we don't have the Achilles tendon shortening in this non-weight bearing position. You'll also see this in the picture, that right ankle has this little divot in the Achilles, and you can palpate and see sort of a gap in the Achilles just when you look at it, that there's like a little gap there. And then the last one is that Thompson test. So the Thompson test, you're putting them with knee flexion, the foot up like this in prone, and you're just giving a squeeze. You're just giving compression to the gastroc muscle. And what you should get if they do not have a tear is when I do that compression, the foot should go into plantar flexion. So you should see the foot visibly raise up. So the toes go towards the ceiling and the foot go into plantar flexion. And it should be obvious, and they should look the same. So remember, Achilles tears usually happen on one side. So you would compare, in this case, the right foot to the left foot to see, okay, does the foot move up the same amount on both sides? So these are 3 clinical tests that, when all done together, are just as helpful as getting an MRI. So it's really important to recognize that, just like with a lot of the other injuries we've talked about, the faster that we can get them into surgery and do surgery, so diagnosing them and getting them into surgery, the faster we can do that, the more likelihood that we are of getting good results. So we really want to make sure we're doing these tests, because if they're all negative and everything looks fine, then we don't need to do an MRI and we don't need to do surgery. But if they're positive, or you suspect that at least a couple of them are positive, then you need to go in and say something. I have to be honest, I have a person that I know very well, and we're both physical therapists. She tore her Achilles, and her story was exactly like the stories you've heard. She was playing tennis, and right immediately after we started doing these tests, they weren't as obvious as I would have liked. So the Matless test was kind of obvious. I mean, there was a difference, but it wasn't huge. There was very little palpable deficit, and the Thompson test was not significantly different. So we thought, well, maybe it's just a little tear. Maybe it's not a big tear. Oh, no. It ended up being a pretty big tear, and obviously this person didn't need to have a repair. So, in China, yes, you have the option of an MRI. That's fine. That's great. But recognize that these tests can also do a good job of predicting an Achilles tendon tear. So if you don't have the access to that, but you feel pretty confident that all 3 tests were positive, you're going to send them obviously to a surgeon at that point and tell the surgeon, look, these tests were positive. I'm pretty sure it's a tear. You probably want to still do an MRI to confirm, but I definitely think this patient is going to need some surgery. So they're going to do surgery if the patient's an athlete, or even if they just want to be an athlete. So most of these people, like I said, they're going to tear it during high activities, like high level activities. And they want to be able to go back and do those activities. So most of the time, the doctors, they're going to say, yeah, let's do surgery. They really only won't do surgery if the patient is really, really sedentary. So if they're really just, they're not going to be going much of anywhere except staying around the house. And then the other reason might be because they have significant diabetes. So we've talked about diabetes with several of these other types of patients, or several of these other types of injuries, especially with tendons, sometimes with ligaments. They may choose not to do surgery if their diabetes is really out of control, because the healing is just not very good. So they're not going to get good outcomes with, again, these more sedentary patients or patients with significant amounts of diabetes, who are also probably pretty sedentary. If they do choose to go non-operatively, then they're going to put them in what's called functional equinus bracing for 6 to 8 weeks. So that means that they're putting them in slight amounts of plantar flexion initially to allow for a shortened kind of tendon position, and then they're working them into more neutral position after that. But they're definitely bracing them to allow for the tendon to heal. At the same time, they're using bracing, not casting, because you do want to mobilize them. So you do want to make sure that you're getting ankle movement while it's healing, because we've talked about this, movement and loading. Ultimately, loading is good. So you're going to basically make sure that they're moving, but you're also doing some bracing. Eccentric training as soon as possible, as soon as you're allowed to start doing more weight bearing. Eccentric training, just like with any other tendon, is going to be helpful. And then shockwave therapy, they have found for partial tears can be helpful. And we talked about this with the tendon lecture. So if you remember, I talked about just the different kinds of modalities that can be helpful. And one of the ones that shows good research is shockwave therapy, especially for partial tears. So the research from 2017, I think this was done here in China, they did 8 sessions for these partial tears, 2,500 times per course over 3 months, and it showed significant faster healing time for these partial Achilles tears. So if you have access to shockwave, go for it. We're going to show you a video of the surgery. So this one, basically, you want to do about 1 week after surgery or after the injury, because it allows for the tendon ends to sort of find their position where they're going to be, kind of their resting position, I guess you would say, after the tear. And then it just makes it easier for them to do the surgery. Most of the time it's done percutaneously versus open. So kind of depends. We'll watch a video here, but so the timing, you may be delaying a couple of days, but you don't want to be delaying more than a week. So here's our surgery. I guess I don't think there's any sound with this one. You can see they're going in and kind of cleaning up and then pulling, and they're going really, really pulling hard, then pulling down, putting in those holes to the calcaneus. Bringing the two pieces together. Securing that into the bone. And then oftentimes they're going to do even more securing of the sutures. Let me see if I Yeah, here we go. Okay, so usually they're going to do something that looks a little bit more like these pictures. You'll see the picture on the top. They're going to do sort of a weaving pattern to really help bring those together and really secure the tendon together. This is another situation where the tendon, they may, because of the way that it tears, they may have to shorten the tendon slightly as they're doing the repair. So, you can certainly get op notes for these. There, as you can see from the bottom picture, there's lots of different suture options available. I don't think it makes a huge amount of difference with rehab, but if they tell you, yeah, there was a lot of fraying of the tendon, and so we did have to really tighten it up more than, maybe they would normally, then that they're not going to get the same amount of dorsiflexion that maybe another patient who had a more clean tear, where they could just kind of bring the two pieces together. And so those patients probably are going to have more dorsiflexion tolerance or ability to get dorsiflexion. Depending on weight-bearing tolerance and weight-bearing allowances, you're more likely to get things like an infection or a DVT. So when they're non-weight bearing, infections and DVTs are more likely. We know that DVTs are less likely when we move, right? So everybody says that, the second that you've got muscle contraction, therefore you've got more blood flow, therefore you're less likely to get a DVT. And that's true for these patients as well. Re-rupture overall has a 3 to 4% possibility after surgery. Unfortunately, I will tell you in China that re-rupture rates are higher than that from what I've seen. It's a big problem, mostly because the surgeons are saying, okay, you're non-weight bearing, or, we're putting you in this brace, and we'll talk about all that stuff in just a second, but we're putting you in this brace where you're in a little bit of plantar flexion for this period of time. And then you go back and you do your follow-up with the surgeon however many weeks or months later, and they're like, okay, yep, my surgery is healed. You can take the brace off and just start walking. They've had no mobility, nothing for however many weeks or months, and then all of a sudden they're told to just walk normally. Guess what? They're going to re-rupture, and I've seen way too many of them. Again, this was probably several years ago. I'm hoping that the patients are starting to get rehab earlier or getting better instruction, so we don't end up with these high re-rupture rates, but I can tell you it was an issue definitely several years ago. The other big issue is decreased plantar flexion strength, especially at the end range of plantar flexion, so at the top of your single leg heel raise. So that would be, again, think of a sprinter who needs to be able to push off and get to the very end range of plantar flexion, and they don't have the power to do that. So oftentimes, a lot of patients, not just, we wouldn't consider this a complication, but it's pretty common 1 year after the surgery to still have decreased plantar flexion strength. 10 to 20% at 1 year, I would say that's actually pretty common. So these people need to be rehabbing a long period of time. They need to really be thinking about that Achilles and the calf muscle for a long period of time. The other complication is decreased sensation of the sural nerve. So if you remember where our anatomy is, the sural nerve goes posterior to the lateral malleolus. And unfortunately, there's the possibility that when they're going in to do the repair, they may end up hitting the sural nerve, or during the injury, the sural nerve was also overstretched. So another thing to keep in mind, you may need to consider if they've got some ma-mu situation that you need to test nerve and test sural nerve specifically. So they're going to put them you're going to be in a cast after the injury, usually with about 20 degrees of plantar flexion before surgery. So remember, they'll usually wait a couple days to do surgery, And during that time, you're going to be in some sort of splint or cast. The surgeon's probably going to say non-weight bearing, but maybe partial weight bearing if you're in a cast or a splint. And so at this point, if you are able to see patients before the surgery, you're going to do a lot of upper body strengthening because it's going to be helpful for using things like crutches after surgery. So protective motion, if they're allowed to do full weight bearing, so you're going to see we've got some different things here for protocol kind of situation. We're really going to mostly say full weight bearing here. I didn't really talk a whole lot about the partial weight bearing. So these are going to be people who are wearing some sort of brace initially, and but they're allowed to be full weight bearing. So the protected motion phase is 1 to 7 days, so the first week. Most research would say that if you can be full weight bearing earlier, that you're much more likely to have better outcomes. So you're not more likely to re-rupture, but you are more likely to get back to work more quickly, get back to sport more quickly, all of those things. So that's why we're going to say that they're allowed to do full weight bearing. However, keep in mind that they are still in some sort of splint, okay? They're still in something. Some sort of stability is provided to the ankle during this first week. So we want to protect that repair, okay? That is part of it. But we're not telling people to be non-weight bearing, okay? We also, again, these are people who either were extremely athletic or mostly athletic or somewhat athletic. So we want to make sure they don't get deconditioned. We need to find ways, with arm bike and different things to keep them in good cardiovascular conditioning. Active dorsiflexion, less than 5 degrees. Okay, so we are not getting to neutral during the first week. We are staying less than 5 degrees. Okay, we also are allowing about 50% of active plantar flexion. So we're letting them do a little bit of plantar flexion. Okay, we're letting them do a little bit of active contraction. Okay, but just less than 50. I would say less than 50%. Okay. By day 3, you can let them do some active dorsiflexion and plantar flexion. Again, I would not say like full, but they can start doing that stuff. And you can get them out of the splint to do those things by day 3. I don't like this picture because it shows them non-weight bearing. You do want to teach them how to use the cast or the brace with full weight bearing. You're also going to teach them the elevation and ice is a good thing, and then monitoring them. So again, they can start doing active range of motion at day 3. You can do, which is basically ankle pumping, right? Ankle going up and down. They can do toe curls, so you can have them like start playing with maybe picking up a towel with their toes. And when they're doing the dorsiflexion, plantar flexion, ankle pumping, then you want to make sure that they don't have pain. So if they have pain, then they're doing too much range. So they need to keep their range within a pain-free range, okay? So when it says day 3 out of splint, that means that you're taking them out of the splint, you're doing active ankle pumping, and then you're putting them back in the splint. Starting the second week, we can start doing more loading, okay? That's phase 2, starting second week. By week 4, we want active, notice this says active, that's really important, active dorsiflexion to 0, okay, at week 4, not before. Well, it could be before, but don't push this. So remember, if you listen to the patellar tendon lecture, this is the same thing. You do not want to overstretch. We are talking active range of motion here, not passive range of motion, okay? Active range of motion to 0 is fine because they're controlling it. You as the therapist are not pushing them into dorsiflexion. They're doing what they can do, okay? So you don't want to push these people into too much dorsiflexion because, again, this can cause strain on the surgical site. So you're not doing passive. This is not passive, okay? By week 8, you can have 5 degrees past 0 of dorsiflexion actively, okay? Then full weight bearing, again, starts at day 14. I know this goes against what it said earlier with the full weight bearing thing, but basically this protocol says you use the brace and you can do weight bearing with the brace, but then by day 14, you can actually start doing weight bearing without. But it's not until week 8, that our goal is to get weight bearing without the brace and walking with good mechanics, okay? So I know these, I'm throwing out a bunch of different numbers here. But this second phase is a long phase. It goes from week 2 to the end of the second month, so week 8. So it's not until the end of the second month that we're really saying, okay, you're out of the brace. You can really walk normally at this point, okay? But by the end of the second week, then we can start doing full weight bearing. So you're still going to probably use this boot. And the boot is something that's going to be used for at least a couple of weeks. You can weight bear with the boot, okay? The weight bearing with the boot is fine. We're going to even start playing with things like balance exercises with the boot. And doing this stuff in weight bearing actually allows us to control our plantar flexor muscles better than doing, let's say, like the TheraBand in non-weight bearing. So doing weight bearing with the boot actually is more functional, and it allows our muscles to start loading in a better way than doing non-weight bearing TheraBand exercises. Patient education, pool therapy, gait training. We're going to do lots of gait training. Gait training in weight bearing with and without the brace when they can stop using the brace. And I really love the idea of getting in the pool as soon as you can. You know, that's not really necessarily easy for a lot of our clinics, but if you can do it, it's awesome. Like I would say, getting them in the pool as early as possible. You're less likely to have any issues with overstretching into dorsiflexion. And then obviously you want to be doing exercises of everything else because we want these people to be in really good physical condition as they get back into the more advanced exercises. So range of motion in phase 2, active. You can start doing passive stretching, non-weight bearing with a towel at week 3, okay? But don't start before week 3, and we're still going to be really, really gentle with the stretching with the towel. So again, the patient is doing this stretching. The patient is doing as kind of figuring out how much they can pull that towel around the foot for dorsiflexion. It's not you as the therapist, it's the patient, okay? We have to be careful that we don't overstretch these guys. We can use the bike early. I mean, as long as they're wearing the splint, you can use the bike week 2, week 3. You just have to keep the splint on, and then after week 5, you can take the splint off. So starting at 6 weeks, you can take the splint off and actually they can push a little bit on the bike. If you want to, if you've got the ability to use the pool, then again, you can walk, you can even run in the pool with your feet in a normal position. So that's why I'm saying I really like the pool, because in the pool you can really play with foot positioning, you can play with push off. All of those things are okay because we're unloading in the pool. You can't really do that as easily, obviously, on land. By week 5, you can play with dorsiflexion in weight bearing. So kind of going back on your heels, that kind of stuff. And then you can also do double leg heel raises. Double leg at 5 weeks, okay? Remember, this is putting load, which is good, on the tendon and the muscle. If you do have access to the pool, as long as the water is at least waist deep or higher, you can do single leg heel raises, but the water has to be waist deep or higher to do a single leg heel raise, so not really low. You can't have it at like hip deep is not going to work. But waist deep, that gives them enough buoyancy that it's okay. Again, gait training without the splint after week 5. Okay, so before that, they've been wearing that splint. They've been wearing something with walking. They have full weight bearing, but they're using the splint. After that, you can start adding in gait training and weight bearing without the splint. So that gets us up to through the first 2 months. Phase 3 starts at week 9, and it goes until the end of 5 months. So again, you'll see that this timing looks a lot like a lot of our other tendon repairs. We did patellar tendon repair, it's pretty much the same. Rotator cuff repair is pretty much the same. We really want to get it to about 5 weeks before we start pushing things. So it's during this 3rd phase that we want our gait to be normalized, okay? We kind of said that with the 2nd phase, but I would really say that we're spending a lot of time like really watching gait during this 3rd phase. We also want normal ankle range of motion. But what I would say is that if you don't have equal range of motion on both sides, that it's okay. So if you don't have the same exact amount of dorsiflexion on the involved side and it's a little bit limited, that's better than overstretching, okay? So I usually explain that to my patients like the first day post-op. Look, I'm seeing you. I know you're going to want to get good dorsiflexion. It's going to feel tight. It's going to feel full. That fullness word is a word you guys use a lot. But that's better than it feeling loose, because if it feels loose, that means that the surgery may not have been as successful and you may not be able to use your muscle as well. So we're okay with it being a little bit tight. Over years, it'll probably loosen up a little bit, which is great, but don't worry about it at this point. Don't worry about it at all during rehab. By the end of the 3rd phase, so about 5 months, we really do want them to be able to do repeated single leg heel raises, okay? We want them to be able to tolerate going all the way through a full range up into that heel raise, single leg, and do that multiple times. I don't know if you need to say 20 times or 25 times, like a 5 out of 5, but you want them to be pretty close to that by the end of 5 months. It's during this time that we're going to start really trying to do fast walking, progressing to slow jogging. Slow jogging, okay? We also can start doing some skill development for sport-specific things and job-specific. So if they have a job that's a higher demand job. For sport-specific, you're doing very, I would say, kind of more basic things. So maybe a little bit of like lunges and maybe a little bit of pivoting. Those kinds of things would be okay. Remember that right now, the timing is really important. From 6 to 12 weeks, this is an important time frame when we want to be loading the tendon, but allowing that tendon, again, to those collagen fibers to line up really well. And so it's during this phase that we need to be loading, and we need to try not to be too fearful of loading, but we need to do that loading slowly. So again, that's why the fast walking is a great way to go, working your way into slow running by the 12 to 16 week mark. So if you can do pool therapy, this is where we're going to start doing some hopping and jumping in the water. But you want that water, well, in this case, it's waist deep, so it's a little bit lower, so you can get a little bit more resistance from above the water. We also can start playing with gait training. If you're on a treadmill or if you are outside, you can have an incline or a little bit of a hill. So you can start doing a little bit more of that dorsiflexion with your gait training. You can do isokinetic dorsiflexion, submaximal isokinetic dorsiflexion, and some plantar flexion as well. But it's like the idea is endurance. So you want to be able to do a lot of it over and over again. And then you're spending a lot of time on proprioceptive training, a lot of time on single leg balance types of exercises. By week 17, this is where we can really start jogging. So again, this is already after 4 months, okay? So this is where you can start jogging kind of in one plane. So again, it's kind of sagittal plane stuff. You can also start skipping, jumping, some easy hopping, and then spending a lot of time working on these triplanar activities. So flexibility strengthening for everything. So watching how their ability to do plantar flexion is affected the rest of the body, okay? We didn't specifically talk about eccentric single leg heel raises. That's something that you also probably want to start doing before week 17, maybe like starting around week 12 or so. You can start playing with eccentric heel raises. So we said double leg heel raises in phase 2. So you're working your way to single leg heel raises, and I would say eccentric, you're going to work your way into eccentric. It's not something you're going to be able to do right away. So they need to be able to tolerate a regular single leg heel raise before you put them on a step and have their heel off the back of the step to do an eccentric heel raise. But you definitely want to be doing that. I would keep trying to do that. That is really important for endurance. So, you know, by the time you're getting to week 17, 18, that, you know, they can start skipping and jumping, and they're going to have the power in the Achilles to do a good jump. About week 20 plus is when we're doing our sport-specific training. This is where, if they're a sprinter, this is where you're going to try to start really seeing how well they can do that push-off during running. About 80% of recreational athletes will get back to their pre-injury level. But it does take a while. So, you know, we talked about complications. At 1 year, there usually is still some weakness, and that is normal. So I make sure I tell my patients that it's normal to not have the same and exactly equal dorsiflexion range of motion. It's also normal to feel weaker on that side even at 1 year. So that doesn't mean you can't return to sports, because if we did our rehab well and the surgeon did their surgery well, then you should have a pretty stable Achilles, but you may still have power problems. You may still feel like my, you know, involved side does not feel like my uninvolved side. So we have to recognize that healing is still happening at 1 year, and strengthening can still be really, really helpful at 1 year. So even though we're saying we're starting sport-specific training after 5 months, that training needs to continue all the way up until a year, at least up to a year, because we are still getting some ability to improve collagen production and give us a really stable Achilles tendon. So don't stop. Make sure they're given a really good home program, a good sport activity program when you're discharging with them, and that they recognize they need to keep focusing on that Achilles for to continue to help it to get stronger, because they're going to need it. There's our references. Okay.